Okay, and here we go. Well, hello everybody, and welcome back to another one of we're still not exactly sure what we are going to call these. Last week I had called them Far Side Simplicity, and well, maybe not. I think we may just go with something along the lines of the big idea. What is the big idea? The big idea is that we can have all kinds of complexities. Well, already losing my tongue already. Complexities, troubles, challenges in the dynamics of the way that the human body works. But what we want to try to do is we want to try to take some rather complex ideas and try to break them down into some nice, simple, understandable, plain English so that A, we have better idea in terms of what we're doing and the potential that we have as healthcare practitioners, doctors, but perhaps even more importantly, so that we can get this information out to the people who need our services the very most, people who are dealing with chronic, challenging health conditions where they're not finding answers anywhere else. And we need to be able to help them with a few ideas that may actually be able to get them into the exact arenas, the right kinds of avenues that they need so that they can get their quality of life back. So what have we got for you this week here? This one here is a research paper, came out in late 2021. I believe that this was being worked on for the better part of around 10 years. So this one's long overdue, and this one is a massive deal for people, and particularly their children, who may be, dealing with juvenile or even adult idiopathic scoliosis. So postural distortions of the spine, and I'm going to emphasize typically of around 20 degrees or more. If you haven't known or chatted with me for very long, I have a pet hate against the casual word of scoliosis. And the reason for that is, if you're being technical, yes, scoliosis is any lateral curvature or sideways curve of the spine, even above, 5 degrees or so. But in my opinion, it really should not be diagnosed as such until you're dealing with at least 20 degrees. And what is the reason for that? Well, A, there's a big difference between a pathological condition like scoliosis, but the difference between that and then if you're just having like postural listing or things like that. But it's because of other research that's come out from the psychologists. A lot of times, especially if you were to say to a young girl or a teenage girl, because it can happen in men as well, but it is more common in women, that you say to her that, oh, you have a scoliosis. And she gets a picture in her head, and for right or for wrong, that picture is along the lines of hunchback. And what happens, the psychologists find, is that these girls go on to have a much poorer self-body image, and that in turn manifests as self-esteem issues and also as other health issues. So I've got a real issue with throwing the word scoliosis around casually, unless we are well and truly talking about the same thing. Unless we're talking about the real deal here. So in this particular article, what we're talking about is essentially the real deal. And so what is this one? This one is research called Functional Leg Length Discrepancy Among Pediatric Scoliosis. A, check this word out, reversible neuromuscular compensation from craniocervical junction misalignment by Dr. Jean Brunet, Luc Jelena, and Jeffrey Chinkowski. Do forgive me if I got any of your names wrong. I hope I did the very best that I can. So this came out of McGill University up in Canada. So let's take you guys through the overall summary first, and then we're going to break it down in terms of what it actually means. Leg length discrepancy and pelvic obliquity have been associated with scoliosis in the literature, and neuromuscular contributions have been mentioned as being possibly involved. It is herein hypothesized that a craniocervical junction misalignment may induce a neuromuscular imbalance leading to functional leg length discrepancy, and that reestablishing a proper alignment can result in a leg length discrepancy disappearance. Okay, so what does that mean? It means that one of the findings that is very, very common for people who have been diagnosed with scoliosis is simply this. It's that whether they're standing up or whether you have them lie down, if you were to look at the relative length of their legs like this, you're going to see that one of them looks crooked compared to the other one. And a little bit later in the article, they kind of talk about, what the difference is. And in brief, there are two kinds of categories. There's what's first called an anasymelia, or a structural short leg. And this is where either because of bony development, physical injury, whatever it would be, that one leg is physically shorter than the other. And so if that's the case, what they talk about here is, okay, neuromuscular contributions being involved, pelvic obliquity, okay? If your body, because of how you have developed, is essentially the Leaning Tower of Pisa like this, your body's going to have to come up with compensations, something along these lines. And it's usually going to be able to do well, but like any compensation, eventually it can get tired, fatigued, start to break down. I want you to imagine the strongest man or strongest woman in the world. No matter how strong they are, guess what? They can only lift things until eventually even they hit a point of fatigue. And when there's fatigue, that's when you can start to have burning, aching, pain, headaches, problems, really any part of the body. And so what's my point? Well, you have this first kind of condition where the one leg is physically shorter than the other. But what they also talk about here are what are known as functional short legs. And this is where the legs are actually the exact same length. But what seems to be going on is something is causing the muscles of one side of the body versus the other to tighten effectively like this. And so what are you seeing? You're seeing the illusion that one leg looks crooked relative to the other. And I do believe it's down at the end of the research, they show an illustration of something like this. And so if you or a family member maybe's been, diagnosed with scoliosis, something like that, or, even if you have a question about posture or something else, this is one of the easiest things that you can do at home. And you don't even need the little fancy measuring devices that they're using right here. But in brief, and I'll try to zoom in a little bit more, and hopefully I don't completely lose it. I might for the zoom in when we pull back there, but let's go with that. Over on this side here, you'll notice in this particular case that, all right, assuming that this person is lying perfectly straight, and you can do this on a bed with the legs hanging over the edge, these two legs do not look the same compared to the other side. Versus, say, something like this. I don't think you're going to do too much better than that. So we'll come around a little bit later and talk more about, okay, so what are these guys actually looking at? How does that relate to the scoliosis? But one way or another, again, what we're talking about here is we're talking about an imbalance in the legs. And as we said, if you can see that there's an imbalance in the legs for whatever the reason would be, it means that the rest of the body is probably going to be having to be making some kind of compensation. Now, here's the thing. Is one of the hypotheses is that the problem is not actually coming from the foot, from the leg, or even from the low back. Where it can come from is right up here, what's called the craniocervical junction. It's the interface between the skull, the C1 vertebra, and the C2 vertebra at the very, very base of your skull, at the very top of your neck. It's what's responsible for doing this, and it's what's responsible for doing this, as well as protecting your brainstem, which is the vital life command control center for everything in your body. Now, without getting too technical into the detail here, you might be wondering, okay, well, what does the upper part of the neck have to do with a scoliosis? Well, this is the hypothesis here. It's that if that vertebra goes off center, so there's been a physical injury, and especially when you're talking about kids, it can be from riding their bikes, sports injuries, it can be from falling down when they're learning to walk, it can even be if there is pressure when they are still in the womb that's basically caused or kinked their head up in a certain way that can actually cause a knock-on effect or some problems later on down the road. Well, whatever the cause might be, if the head goes off center, something like this, then in order to maintain that relative balance in the relative center of gravity, what your brain is going to reflexively do is it's going to recruit the muscles from the lower down part of the spine in order to keep this balanced, because one cannot function very well if their brain is crooked. I mean, if you had to choose between, you can sacrifice either your brain or your body, which one is it going to be? Well, the brain is the one who's actually in control of things here. So it's going to say, no, I'm not going to let you sacrifice me. Sorry, body, you're up. And the hypothesis is that it's going to start to change all of the bone structure, the ligament structure, the muscle tone, the tension, all that sort of stuff, all the way down the spine. And it can actually be one of the things then that's contributing to scoliosis, particularly idiopathic scoliosis, which means that from a medical standpoint, there's not a leg that's physically shorter. There's not a half of a vertebra that's been developed, and so the spine is wonky for that reason. It's that this is a functional condition. There's not a anatomical reason for that. And so it's otherwise can oftentimes go as a mystery. And so people are told, watch the condition, or you might need to brace, you might need Harrington or surgical rods if it ever gets severe enough. And the way that we look at it from an upper cervical perspective in the Blair technique, which is the kind of work that I do, is we're saying, okay, well, wait a minute. If the center of gravity of the skull is what's caused the body to compensate like this, is it possible that if you correct that misalignment, that it's going to take and allow the head to actually right itself coming back to center? And as it does that, then we should have a positive knock-on effect where those other compensations to the spine may actually have the opportunity to go away on their own. And so in this particular research thing, that's what they are talking about and they're looking at. And they're saying, okay, well, we're not going to measure spinal curves and all of that sort of stuff in this particular case. What we want to do is just something really basic and easy. We want to see, okay, do we have people with known scoliosis? And if we make a precise correction to the upper part of their neck, restore the alignment and the center of gravity there, do we see a change down in the relative looking length of their feet? Because if you come into the office like this and your legs are crooked and you tap on the neck and the legs balance out, well, by default, there's been some kind of a change with everything else in between. That is the hypothesis. That's what these guys are looking at here. So what did they do? They took a total of 40 consecutive children with scoliosis, 15 to 50 degrees angulation, which 15 degrees, again, that's where it starts to become a little bit significant. 50, that's a really, really big deal. And either young kids and or teenagers. Even though it is a relatively small size, n equals 40, so it was a population study of 40, it's relatively small, do take note that it was consecutive. In other words, these were not where they were cherry-picking individuals and just sort of putting together the best of the best. They said, okay, these are the 40 people who have come in who meet this study criteria, and we're just going to report for every single one of them. In other words, it means that even if it's a small population side, odds are the findings are a little bit more significant. So the children were presenting with signs and symptoms of craniocervical junction misalignment and evaluated with specific x-rays. Patients for whom the misalignment was confirmed received a craniocervical adjustment, right up there, for their realignment. So what does it mean? It means that they didn't just start adjusting these kids willy-nilly. What they did was they did a few physical neurological assessments first. So they already knew and had been previously diagnosed by their medical doctors, okay, yes, these children have scoliosis. So what they also did then was they said, okay, we're going to have a look. Do you actually have evidence that there's a mechanical misalignment with the vertebrae in your upper neck? And it's like, okay, yes, they do. So what they did then was they took a series of very precise x-rays. In this particular case, they customized them based on the individual's own bony anatomy, and that's something that you can't normally see even with standard x-rays because they're taken from the front, the side, things like that. But human beings and our bone structure is actually orientated three-dimensionally. Unless you take those differences to account, you don't know what's actually going on. So that's what these guys did. They found out the exact location, direction, degree of the problem, and they said, okay, well, what we're going to do is we're going to make a precise correction there, and we're going to see what happens. Now, I will jump ahead just a little bit forward right here, because a lot of times people, who aren't familiar with, the difference between an atlas technique or an upper cervical care, they just think, oh, okay, it's the same as, general chiropractic. It's like, not really. So what upper cervical is it is it's a unique method in chiropractic. And so it does originate from standard manipulation, things like that, but doesn't use it anymore. We changed that a long time ago. We realized that in order to correct the joint, you don't always have to push it to its end range of motion, push it just a little bit farther. And so what we do first is, if we can determine what's the exact amount of, misalignment, degree, all of that sort of stuff, then really all that you need is only the amount of force that you would need to click a pen if directed at the exact right angle. And that can be enough then to overcome what's actually causing that vertebra to stay stuck, not be moving the way that it should be. So the adjustment procedure that they used is very different from standard chiropractic manipulation. It does not entail either bone articular cavitation, in other words, no cracking, no neck rotation, torsion, or twisting, and softly interacts with the craniocervical junction to reverse the neuromuscular imbalance instead of interacting where the pain and deviations are, considering that the postural anomalies elsewhere in the body are compensatory to the culprit, craniocervical junction misalignment. What that means is it means that you can have pain and problems in other parts of your body, but we're going to focus on what do we believe is actually causing that kind of condition in the first place. Oh, and did I say again, no twisting, no cracking. So sometimes people say, oh, geez, these were pretty young kids, 7 to 16 years old. Is this really appropriate for them? In this particular case, when you weigh up risk reward, especially when you're dealing with something like a scoliosis, yeah, it's pretty good. And so would that be appropriate even in kids that age? I would say, in my opinion, yes. So check this out. So what they did was they found that the kids were showing something like this. They were showing that leg length inequality, something like this. And what did they find it was on the average? And again, I want you guys to please keep this in mind, that these are not fully grown adults yet. The mean leg length discrepancy was 11 millimeters at their first presentation. Normal for a fully grown adult is 3. Ask any structural engineer, doesn't matter whether you're building a house or building a bridge, they're going to say, what's the tolerance of error? 3 mils. Guess what? Human body is the same. Beyond 3 mils, yes, it is still able to compensate, but it's going to have to find some way of doing it. And so these kids, not even fully grown adults, they were over 3 times the normal limit. Almost 4 times over the normal limit on the average. And so what I say, if there's ever a way that you want to have just a relatively outside, approach, way to measure, is a person's body under neurological, physical, ligamentous muscular stress. Have them lie down on the table, look for that imbalance in the legs like that. If it's more than 3 millimeters, there's probably something that's worth investigating right there. So what did they do? They made the correction, and what did they find at their first follow-up visit, which was on the average about 2 weeks later? 90% reduction. It dropped all the way down to just over 1 millimeter after one initial correction. So they went, sorry, I keep cutting back and forth here. They went from this to this. 90% reduction after the first correction. They did find that when they checked up with these kids again, a year plus later, I believe in this particular research study, it was 16 months, they found that the average that they found was 2 millimeters. So again, under the normal limit, and 82% less than it was before. And so what did we say? We said, okay, if you make a little tap on the neck and the legs were crooked before, if the legs balance out, by default, what happened to the muscles, the ligaments, the bones in between? There had to have been some kind of a change. Now, in this particular study, they didn't study that, but they said that based on this relatively non-invasive test, the results suggest that there's an association between leg length and discrepancy and craniocervical junction misalignment. In other words, there's a connection between the upper neck and the imbalance in foot that shows up in scoliotic children. And if the leg length discrepancy is reversible by means of correcting the neck, what they hypothesize, or again, what present, is that there may be benefit for actually helping with the functional curves, the tension and all that sort of stuff that's present for these kids as well. Again, they don't conclude that that is 100% the case, but they're saying, that's not too far of a connection there to, make a reasonable association. So here they have, right through here, I've sort of scrolled through it again here, but this was the, again, average. This was the average imbalance that they found in these kids. And again, where's normal? Normal is here at this level. So after their first follow-up, that's what FU stands for, apparently. First follow-up dropped them down to 1. And their second follow-up, which was 16 months later on the average, was still under and within the normal limit from those initial corrections. And what they found, and this is oftentimes one of the beauties when you're working with kids especially, is because unlike adults who oftentimes have had their issues and their injuries for months, years, or even decades sometimes, and as a result, it takes more persistent work over a period of time. They found that these kids, they needed their initial correction, and then they only needed, on the average, 1 plus or minus 1.6 thereafter. In other words, they said, okay, 43% of the kids, that was the one adjustment they needed, and they were good to go. Others, they needed 1, others, they needed 2, others, they needed 3. But what that means is it means that they did not need to keep going back to see the chiropractor every couple of days over the span of that 16th-month period. And if and when they did find that that leg length inequality had returned, the vast majority of the reason was why? Was because the kids had a physical injury. They had a fall on either the backside, on the hips, they were doing gymnastics or something in gym class, or they had a hit. Something happened and it caused a relapse of their condition. And so that's kind of what they're showing in this little thing right here. Okay, here were the kids doing, okay, this was one he was doing, I don't know if it was a he or a she in this particular case. So this person, they were doing great until 511 days after their initial correction, a year and a half, they had a fall on the buttocks when they were exercising. That imbalance returned, they made a correction, and boom, they came right back as they were. Another case, fall on the backside on the stairs. This person, it took them a couple times to get them right, but same thing. Falls. So what's the point in that I'm saying in all of this right here? Is it seems that one of the precipitating cases, again, for what's actually contributing this is physical injuries. So we come back to that word again, idiopathic, cause unknown. There is some evidence here that is suggesting that imbalance in the body is a consequence of a physical injury. And so idiopathic may mean that when you're looking at a potential solution, rather than looking exclusively in the chemical realm of just, drugs, things like that, rather than looking purely at the mental side of the equation, the psychological impact, it means make sure that you don't dismiss the significance of the physical side of the equation. And ideally, if you can do something that can be done without needing to go to the point of surgery or braces or any of these other things. Yes, if it's severe enough, you may need that. But if and when, you're still dealing with that mechanical misalignment up through here, wouldn't it be nicer if you could actually have that area free of the interference, and so that if and when those additional devices are needed, that the body is able to heal with the flow rather than continuously fighting against it? At least in my opinion, I think that that's at the very least worth considering. So, little breakdown of this very, very important article again for parents, their kids, or anybody else who may be concerned about spinal curves, scoliosis, anything like that. Again, this article is not saying that you correct the upper neck and scoliosis goes away. No, it's not saying that in the least, but it is saying that, whoa, there is a very substantial change showing up in these kids in particular who have scoliosis. It's been diagnosed again by the medical professionals, and one of those imbalances, one of those precipitating factors, is able to be resolved when that upper neck is put into its proper alignment, motion, and all that sort of stuff, which I think is a pretty cool thing, but also something that I think, is really important, as it gives hope to a lot of people, a lot of parents especially, who would otherwise be looking at these things and wondering, what and how are they going to be able to do things to help their children. So hopefully that will save you a little bit of time, a little bit of challenge going through this article here, translated all for you in English, and hopefully after all of that, you've essentially gotten the big idea. So if you guys have enjoyed this video, as always, if you've got another one of these awesome articles you'd like me to go through, and again, please, we would say, let's stick to the stuff I'm competent in, talking about conditions and the relationship between the upper neck and as it relates to the lower body. Please, that would be very, very good. But if there's anything you'd like me to go over, talk about, please, I'm all for it. If, of course, you've enjoyed this one and you want some more videos, you do need to be sure that you're going to subscribe here on YouTube, where we're most likely going to be posting this. But then if and when, of course, you may know somebody either who, is concerned about or is dealing with something like a scoliosis, postural curves, different kinds of things like that, please do, send them this link, because ultimately, if we're ever going to make a difference, it's only going to happen when people are sharing the right kind of information from the right sources, so that we can get them to the right kinds of people wherever they would so happen to be in the world. So thank you guys very much for your time watching this one here, and I look forward to seeing you next time. Bye-bye now.